I'm going to start this by saying equity. This is what this is about. This is about equity. And this is Koira for Rukahukahu, which also is known as Koira for Purukahukahu locally. Lungs for Life. And this is a project which started in counties, I guess, but started with CAS really, and is a joint project of the NRA now with Northland, with counties, with Auckland, with Waitemata, and crucially including the Bronchiectasis Foundation. And I'd like to just mention Camron Muriwai, who heads that organisation. They have a very good website and lots of information, and they've been crucial to the development of this project. Kingi, age 13 months, 35-weeker, 2.3 kilos. This presentation's available, by the way. Bronchiolitis submissions, age 2 and 3 months, nothing unusual there. Next winter, bronchopneumonia. Is he at risk of bronchiectasis? Yes. So what's the standard of care we do for someone who's at risk of bronchiectasis? What do we do with these kids? And if you ask paediatricians, there'll be lots of different variations. It's just bronchiolitis, don't worry, too. He needs intensive clinic follow-up. And the families are not sure what's happening. So does he need anything extra, I guess, is the point of this presentation. So this is a high risk. We see lots of these kids. And I've been seeing them since 1985, and I'm a bit embarrassed we've only got to this now. Just on that background about pre-bronchiectasis, the recurrent lower respiratory infection going to bronchiectasis, just the main cause is early severe repeated LRTI, although most of you will know we actually had a very bad adenovirus 7 outbreak in 2015. There are specific causes. Just that repeat LRTI, under 2, we think those kids get 5 to 10% of them get bronchiectasis, which is astounding, really. Kaz's point about early treatment of bronchiectasis improves the outcome and can reverse it. And then this lack of a standard approach. So what I'm going to present is what we've agreed in the NRA and presented recently as an overall program. And because of time constraints, I'm just going to dive straight in. Kaz and I did the Healthy Lungs study in 2010 to 14, following 400 kids, and basically found 7.5% of the kids we followed developed bronchiectasis, although we didn't prevent it. In 2016, all the paediatricians in the North Island got together and said, we've got a problem with these kids. What are we doing about it? What is our systematic approach to them? And the Counties Manukau Equity Campaign adopted us through a good training intern putting my name forward. Yes. And said, when we looked at these kids, we started this campaign, we looked at under 2-year-olds, and we were seeing, these are ones with repeated lower respiratory infection and pneumonia, and we were seeing about 50 a year in counties, and we thought that's probably manageable to do some sort of program for 50 kids a year. With measles, it got to 100. With COVID, it dropped to 20. So from 2019, we've been developing this regionally, and this is my first Northern regional program, which is obviously going to come more and more into practice, and it's with a community focus. And we launched it recently. We want to reduce inequity. Why do we need it? This is about Maori and Pacific kids. This is what it's about. And we've normalized poor respiratory health, even in the industry, don't we? We expect it. The kids get sick. It's always the Maori and Pacific kids in hospital. And there's lots of other things. Asthma is the same story. A recurrent viral wheeze, the same story. And they've got lots of other things like hearing loss and skin problems, eczema. So what is it? So this is a community-focused program. It's not based on paediatric clinic attendance. It's not based on symptomatic presentation as we rely on our 2 systems. And it isn't relying on the families themselves to bring up the issue. I think that's important. It's predominantly nurse-led, although it varies between the different DHBs, relationship-based, patient-centered, and flexible. And basically, we've got to link this in with everything we do for kids. So what we tend to do in New Zealand, isn't it, is focus on one point, the breathing. We'll fix that, and the rest can go hang. So this has got to link in with everything else we do. The key message is, Kaz has mentioned, I'm a Lungs for Life child, and this is about us recognizing these kiddies have a risk. And I think having a label is really good in the system. I hate labels, really, but when you actually say, I'm a lungs for life child, there is a risk of bronchiectasis and other things. Cough-free, the way to be wise, immunised. With COVID, with the lack of respiratory infections, serious bacterial infections drop too. And as it comes back, the serious bacterial infections are coming. So routine immunisations are really important. Free flu immunisations for targeted kids, we only do about 25% of the kids that are eligible. So, important. I am passionate about this. So this is on the Starship website. This is what the program is, just to run you through it quickly. And thanks to Alana, whose presentation it really is, who's talking next. So if we focused on hospital because that was the thing we had where most of the severe kids ended up. There is alternative pathways for chronic cough in the community and in other circumstances. This is about children in hospital. So I admit under 2, lower respiratory infection. The criteria for enrolment, 3 or more admissions to the ward with LRTIs, and we've added in high clinical risk as determined by the SMO. And this came from that adenovirus epidemic where the kids were hit hard in the first episode. The family would have the discussion, an alert in the hospital system saying this is a lungs for life child, this is for the northern region, a letter to primary care explaining it, and the Whanau information sheet. And in hospital we'd look at ARFI, smoke cessation, safe sleep immunisations, and medical investigations required. We have a very specific chest physiotherapy pathway for those who need it, and a dysphagia screen because dysphagia is a common cause of bronchiectasis, and we can do that in hospital. These are all on the Starship pathway when you want to look. And then the community reviews. This is largely done through nurses and community nurses, but different within the different DHBs. So the acute visit, as you would, post-hospital, a 30-day review, are you better? Recycling, are you better? Are you better? 3-month review, 1 year, 2, and 5. We want to ensure complete resolution and that if there are symptoms, we can, start the process again, and with free access to a paediatrician advice or review. Now, if you come to emergency department or GP or a review, then again, as Kaz points out, the guideline for managing lower respiratory tract infection doesn't really encourage antibiotics, but for these kids we should. And, looking for wet cough too and trying to listen for wet cough and look at the crackles. Physiotherapy can be considered if they meet the guideline pathway. And then if possible, make sure they get better. And that's an important point, this sort of get better, get better. And then we have contact for the Lungs for Life team locally. So we've got contacts, and I'll show you in a second. And we want to review them at 5 and collect data to make sure they do get better and the program works. And we've got an alert on the hospital system. We are going to measure health outcomes. And this is to really ensure that the program works, but also to look at the other aspects of health, because these kids have lots and lots of health issues. And at age 5, look at the diagnoses that we've found to see if the program is effective and working, because it is a development. The Whanau voice. The thing I'm most proud of is that Kaz and I are doing a healthy lungs study follow-up. And part of that will be a co-design project with families to try and work out what works for them, because as a group, they find it very difficult to engage with services. We will be, through the Bronchiectasis Foundation, taking Whanau surveys regularly. And we have a nice Whanau information leaflet that's been looked at by TKR experts in Northland and counties and has been the subject of a lot of debate, but we're quite proud of that coming up. Starship guideline, it's now available there. And we have regional contact details. So as primary care with Kingi, if they're on the Lungs for Life, you can email us there or contact urgently, but you can email to say, I've got a Lungs for Life kitty, I'm not sure what's going on, can you help or see them or advise me? So there is a Lungs for Life contact at all the DHBs, and we're all doing the same thing across the northern region. I've got 5 minutes. Just the Healthy Lungs study, Kaz and I followed 400 kids, and you can see after 2 years, which is the pointer? Is that a pointer? No. No. Oh, yeah. So we've followed up 400 kids by intervention control. There's no difference between them except the kids in the intervention group were diagnosed with bronchiectasis. So at early identification, but you can see at the end of 2 years, the kids still had, a third of them still had a wet cough, abnormal examination, abnormal X-ray, and lots of other diseases. I don't think, when we originally did this pilot study, we include lots of things that were known to cause bronchiectasis, but this was too complex, and so we've changed it to just be recurrent respiratory admission. I'm sorry, I know this is just the pilot study. When we did this in counties, we identified 92 children between March 2017 and 2018, and 4% were diagnosed with bronchiectasis by then, and half had had a subsequent admission. So we thought we were chasing the right group, and 50 a year wasn't overwhelming, and about 2/3 of them were followed by paediatrics already, so known kiddies. When we did the Epidemiology Service, looking at the whole of Northern region with recurrent respiratory admissions, it's 20,000 plus, we found, looking at diagnosis of bronchiectasis at the age of 5, we found 336, of which 245 had had this recurrent respiratory admission thing. And when we looked at, did our tool predict bronchiectasis at the age of 5, we found a sensitivity of 54%, a specificity of 90%, which meant there was a positive predictive value about 7.8%. So recurrent respiratory admission, probably a 7.5% risk of bronchiectasis. And you can argue this, and we're doing more detailed work on that. Those links are really useful. Persistent wet cough in children, etc. But thanks to these guys who've all helped. Thank you.